Welcome to our town hall today with our MGH Beacon Hill primary care practice. We are so happy that so many of you could join us. My name is Susan Edgman Levitan, and I'm the director of the MGH Stokel Center for Primary Care Innovation, and I will be the moderator for today's call. A few housekeeping rules before we get started. Everyone on the call except for the speakers is muted to eliminate any background noise. You can view the speaker on your full screen, or you can go to the gallery view in the upper right corner to see all the participants. So when you go to the upper right corner of your screen, you'll see a little place where you can click on speaker view or gallery view, and it's up to you which one you prefer. If your picture becomes jumpy or out of sync, click your stop video in the lower left corner, because sometimes we have so many people on the town hall that it slows down the internet, and that causes the pictures to either freeze or get jumpy. So if you start seeing that happen, please close your video and you'll still be able to see and hear the speakers. We are going to spend some time answering your questions today once our presenters finish. So please use the chat feature, which is in the very center of the screen across the bottom. And we also ask you to please not share or ask any personal medical questions, because everything you write in the chat can be seen by everyone. And we also ask that you please not show us any rashes or anything that you'd like advice about, because again, you'll be sharing it with many, many people that are on the town hall. If you do have a medical question, we encourage you to reach out to your doctor directly. We're covering a lot of information today, and everyone will get a copy of this recording probably next week with a lot of other materials. And we want to make sure that you know that you can share those recordings and those materials with anyone else you'd like. We're very happy to try to get through as many questions as possible, but sometimes we're not able to do that. But if you do have an important question that we don't get to, please reach out to your doctor. We have several excellent speakers today. I'm going to introduce everyone at the beginning, and then they will each in turn hand it over to the next speaker. So we're first going to hear from Dr. Riley, who is the medical director at Beacon Hill. Then we're going to hear from Dr. Rodriguez, and then Dr. Calcoran, and then Dr. Jacobson, and then finally Dr. Della Catsios. Dr. Rodriguez, Dr. Calcoran, and Dr. Delacatsios are all primary care doctors at the Beacon Hill practice, and Dr. Jacobson is the medical director for the Continuum Project in the Division of Palliative Care at Mass General. So with that, I'm going to turn it over to Dr. Riley.
Hi, everyone. Thanks for joining the Zoom today. Our goal is to give you some information about coronavirus that will hopefully supplement what you already know, and then to give you some information about how to navigate the medical system at Beacon Hill and at the hospital, because many things have changed in this pandemic. So I'm going to give you a little bit of background on coronavirus. Coronaviruses were first discovered about 40 years ago, and for many years they were thought to be just associated with the common cold, and never severe until 2002, when we first saw SARS. And after SARS, about 10 years later, in 2012, we saw MERS, Middle East Respiratory Syndrome. And it took about 8 more years until we saw COVID-19 come out of Wuhan, China. And with SARS, there were about 8,000 cases, MERS about 2,400, and of course now with COVID-19, we've seen over 8 million cases worldwide. So how do we get COVID-19? At this point, we have 6 months worth of data to tell us how to understand how to catch and avoid getting COVID-19. So we know that it's by person-to-person transmission primarily, and by droplets. Droplets are saliva or sputum that come out of our nose or mouth while we're doing day-to-day things like talking or singing or exercising or eating, also when we sneeze or cough. And those droplets are fairly large size, and when they come out of our nose or mouth, they don't tend to aerosolize in the air. They tend to drop to the ground within a few feet of where we are standing. So when we wear our masks, it prevents those droplets from leaving our bodies and going on to other people and spreading infection. And of course, if we're wearing a mask, it prevents droplets from other people from reaching our nose or our mouth and infecting us. And then we hear a lot about social distancing. And of course, we're supposed to say 6 feet or further away from people when we're not wearing a mask. And that has a lot to do with those droplets. As I said, many of those will drop within several feet of where we are at the time. So if you're talking to a person or you're near them and you don't have the ability to have a mask with you, if you distance appropriately, your risk for coronavirus goes down significantly. So you can imagine if you wear a mask and you socially distance, that risk goes down even further. We also know that person-to-person contact can cause the virus. And so if you touch a surface that another person has touched, like a doorknob, or if you shake hands with someone and then you get the virus on your hands, and then you touch your mucous membranes, which are your eyes, your nose, or your mouth, you can contact the virus that way. So frequent hand washing is also another thing that's been recommended widely, and that's the reason. Let's say you do all of those things and you get the virus anyway, what would you expect to happen? So sometime between day 2 and 14 from your exposure is when you would start to develop symptoms. Most people develop symptoms around day 5 or 6. And those symptoms can be typical upper respiratory symptoms, so a cough or runny nose or nasal congestion. You can have headache, fever, or chills. There are also some unusual symptoms of coronavirus, like lack of sense of smell that you may have heard about in the media, or a purplish rash of the fingers and the toes. And then some people have some shortness of breath associated with coronavirus. If you do develop symptoms, though, most people have mild to moderate symptoms, and 80% of people feel better after 2 weeks, within 2 weeks. In terms of infectiousness of the virus, I think a lot of us are worried about that. You know, how long do you need to stay away from somebody? And we do know that although some people stay infectious for several weeks, sometimes even up to a month after their illness, most people do have their infection resolved within 2 weeks, and at that point would test negative and not be able to give it to others. I think just one more thing I'd like to mention about that is that we're hearing a lot lately in the media about people who have no symptoms and if they're able to transmit the virus. And we do know that there are a fair number of people who can be completely asymptomatic and have the virus. And when they were doing population studies and testing people and finding out that they're positive for the virus and then testing them again in the absence of symptoms, they're finding that their viruses, their ability to transmit infection is lasting about 2 weeks, the same as somebody who has symptoms. So simply screening someone for symptoms, if you're going to get together with a family member or a friend, simply screening them for symptoms is not quite enough to protect yourself from the virus. So as we think about moving into the summer months and the fall, these restrictions on us are being lifted in our activity. It's important to wear your mask and socially distance and wash your hands, and not just use no symptoms alone as a reason to get together with our family and friends. So I hope that was helpful. I'm going to let Dr. Rodrigo Rodriguez speak a little bit on what we know about testing at this point.
Thank you very much, Dr. Riley. Welcome everyone, and I hope everybody's well, healthy, and safe. Same for your family. I was asked to talk today and go over the current COVID tests that are being done at Mass General Hospital. And during our discussion, we are going to go over how they are done, why they are done, and what do they mean, right? Because whenever we do a test, we want to know why we're ordering and what we'll get from the results of those tests. So The first test that, and I think it's the most commonly heard, is the PCR test. So the PCR test done at Mass General is also called the nasopharyngeal swab. And that test, basically a technician will insert a special 6-inch, about 6-inch cotton swab up both nostrils and moves around for a few seconds and send it to analysis. It shouldn't be painful, but it may be uncomfortable, you know. This is what we call a diagnostic test. What it means is that it will check for the presence of the virus in your body at that moment. Okay. Um, uh, uh, the other test that we are doing here is a very talked test, which is the COVID antibody test. And differently from the PCR test, the antibody test is a blood test. And as the name implies, it will check for the presence of antibodies against COVID. This test is mainly used for epidemiologic purpose in serologic surveillance, but can also help with diagnosis. And sometimes patients with COVID-like symptoms may have a negative PCR test, and because of the symptoms are so characteristics of COVID, um, antibody tests can be used to confirm and sometimes rule out the infection. Um, the antibody test will basically give us information about whether the patient was ever infected with the virus, even if he or she never really had any symptoms. And there are several challenges associated with this test. And one of them is we really don't know what it means. Having a positive antibody test, again, mainly describes that that patient was infected with COVID. Their body responded forming antibodies, but we are not sure if they are immune or protected against future infections. We are also not sure if they are immune, for how long that immunity will stay present. And unfortunately, at this point in time, we're not sure about those answers. And we do need those answers to advocate for a widespread use of this test. Also, because of that, there is no current role for the serologic tests in patients, if we have a prior positive PCR test that are currently asymptomatic. The turnaround time for those tests, both PCR and serologic tests, is pretty good. It's about 24 hours. Also, they have a very good sensitivity and sensibility. What it means is that they are able to confirm the presence or absence of virus. And those results are what we call time dependent. The PCR tests, they will be more commonly they will have a higher probability of being positive during the first 1 to 2 weeks since the beginning of the symptoms. And then that the probability starts to decrease. At the same time that the probability of the antibody tests come back positive starts to increase. Regarding MGH and our current testing capacity, I think we are doing a great job. And at this point in time, we are open to provide tests at the provider's discretion. And of course, this is continuously revisited depending on the demand and testing capacity. I will stop for now. I'm more than happy to answer any questions in the end of our talk. And now I'll turn to Dr. Sarah Calcora.
Great, thank you. So I'm going to talk a bit about what it's like being a patient right now if you need medical care. And the first thing I want to stress is that the way you access our office, whether it's your doctor or front desk staff or our nurses, that has not changed at all. So continue to use the same phone numbers to call the front desk, continue to use Patient Gateway to get in touch with the medical assistant or your doctor. And then if you need help after hours, you can continue to call and have your physician page. So that has all stayed the same. What's changed a bit is where and how you're going to receive care. And that's really going to depend a bit on the reason that you need to be seen and somewhat on your preferences for how you want to be seen. So many of our visits right now are being done virtually. So our preference would be ideally to do a video visit so that you and your doctor can see each other. Maybe if you have a rash or a swollen joint or things that you can actually show your doctor, we're able to do that through video visits. Obviously, there might be times when you don't have access to a laptop or tablet or smartphone, and in those cases, we can do telephone visits instead of the video visits. Even physical exams and annual wellness visits can be scheduled through a video visit, but depending on your preference, and if you prefer to do these in person, these can also be rescheduled to an in-person visit sometime in the fall. So that's the options for people getting virtual care. But then there's also, what if you need to be seen in person? Either, you have an urgent issue going on, or you talk to your doctor and they want you to come in and be seen in person. And there's a number of options for that too. So the first is for people who have symptoms that are concerning for potential COVID-19, so cough or fevers, shortness of breath, you'll often be referred to either get testing through a drive-through site, or you may be sent for evaluation to see a provider at the respiratory illness clinics, of which there's one at the Mass General main campus, and then there's one in Chelsea. And then for people who have COVID, it's already been diagnosed, but still need to get routine care, perhaps for a reason that's not related to their COVID, there's specialized clinics where we're seeing patients for that. So and that in that context, you may be seen by your own primary care provider, or you may be seen by a nurse practitioner. And then the third is for people who don't have COVID and who don't have symptoms of COVID and just need in-person care. So these patients will be seen by a member of our staff. You may not end up being seen by your regular primary care doctor. It may be one of us, some other member of the staff, depending on the time frame that you need to be seen, because different doctors are seeing different patients on different days. And we're allowing more time between visits to give us adequate time to clean the rooms and to make sure there's not too many people in a waiting room at a given time. When you get to the practice, everyone's going to be wearing a mask, and then we have masks and hand sanitizer available for you as soon as you enter the practice. All the chairs in the waiting rooms are spaced 6 feet apart, and everyone's being screened for symptoms of COVID, sometimes multiple times before their visit. So really, we're trying to make it as minimal as possible that you'll be sitting near anyone that has any sort of symptoms of COVID, because they're going to be seen in a different area. And then finally, if you actually need just blood work or you need imaging, you have the same access to the same sites. So you can still go to the MGH main campus, Waltham, North Shore, Chelsea. And again, they're also minimizing the number of people that are waiting at a given time, making sure that everybody's wearing masks. And then the last question, which we've gotten multiple times, is it safe to go to the emergency room? And the answer is yes. If you're having an emergency, you should still go to the emergency room. They're taking all the appropriate precautions to make sure you guys are safe and they're safe, and then that you're getting all the care that you need appropriately. So please don't hesitate if you need to go, please go. other medical conditions don't stop just because COVID's here. And with that, I'm going to pass it over to Dr. Juliet Jacobson.
Thanks, Sarah. Hi, everyone. I'm Juliet Jacobson. I'm one of the palliative care doctors here at Mass General. I've been here for about 15 years. And before all of this, before the pandemic, my job was to train clinicians in communication. And so I give workshops. We use actors and small groups to help clinicians learn skills to have what we call serious illness conversations or matters most conversations with patients and their families. And so these are conversations about people's goals and their values and their priorities for living now, and also for if they got very sick. So that's what I was doing. And then all of this happened and my role changed. And I found myself actually in the emergency room, gowned up with my cell phone, talking with patients. And I would call and have their families. I learned to use FaceTime very quickly so that we could see families and so that we could have conversations with people to understand a little bit better what their priorities would be if they did get sicker. And we know these are important, these conversations, because we know that if we talk with people about what's important to them, that they're more likely to get the kind of care that they want. And so that's very important. And also, we know that patients generally report better quality of life and actually better mood when they have these conversations with their clinicians. And I think some of that is sometimes just, even though we don't always want to think about the hard stuff, sometimes acknowledging the elephant in the room and kind of getting it on the table does help unburden people. And so we believe these are important, these conversations. We also think of them as a missed opportunity. We know that only about a third of patients report having had a conversation with their primary care clinician or with their other clinicians about their goals and values. And so we know that there are a lot of people who have yet to have the opportunity to engage in thinking about this. So at Mass General, even before the pandemic, we've been very involved in trying to have more of these conversations. It's the reason I have a job, and Dr. Peter Slavin has been very dedicated to this mission. He actually chaired a task force. There were about 40 people, leaders, nursing, patient care services, physicians, surgeons, oncologists, primary care, social work. Everyone in the hospital was on this committee. And he actually says it's the only committee he had asked people not to sign up for. There was such kind of an interest in trying to think about how we could do this better. And so for years, we've had a vision for having these conversations. We actually adopted Atul Gawande's program. He created a program for this. It's called the Serious Illness Care Program. And it's part of how we train our clinicians to have these conversations. You wouldn't believe it, but we don't learn any of this in medical school. And I think medical schools are changing, but certainly my generation, there was no one told us how to talk with patients about these important values. And so what Gawande did, Gawande's such a bright man, and he made those checklists for surgery. So he was kind of making things better by creating systems. So he actually created a checklist for communication. It's a piece of paper. Clinicians are taught to hold it and actually have a conversation with patients so that they don't forget some of these important questions. And so that I think it just helps everyone stay on track. Anyway, that's what we were doing. We had trained over 1,300 clinicians. We'd had over 4,000 conversations with our patients. And then the pandemic happened and it kind of changed for us. What we realized is we changed. We, even more than ever, felt this real importance of knowing what is important to all of you. So we changed. And then we had patients change. Patients were calling our office and asking to talk with their clinician to talk about what they wanted if they got really sick. And that was, I can tell you, that was a shift, because usually the way it kind of is it never seems like the right day and people are not sure they want to talk about it. And so it always feels like maybe another day is a better day. And that was just very different once this illness was a part of what we were living with. So we have shifted our focus, even within the pandemic, to be reaching out to patients to have these conversations. You may have been called by your primary care doctor. We actually had a team of clinicians calling patients to make sure that we were able to reach patients who we felt could benefit from one of these conversations. And some of the questions that we ask are questions like, what are your hopes? What are your worries? What's most important to you if you did get very sick? We also ask if you have a healthcare agent, someone who could help make decisions if needed. And actually, we've been asking people to pick 2 people, just in case the person who you live with is your healthcare agent and they can't come into the hospital because they might also be sick. And then we ask people to think about questions like, are there abilities that are so important to you that you couldn't imagine living without them? I asked my one patient this, and she told me driving. She's like, I drive everywhere, and that is so important. And so it's helpful to think about what are the things that are important to you. And also this question of how much am I willing to go through for the possibility of more time? What's my reserve? And you don't have to fully have the answers to all these questions, but sometimes thinking ahead a little bit is helpful. It's helpful for you if you meet me in the emergency room and we're trying to think about what a plan of care might be like. It can be helpful if you've thought about some of this before. And it can be helpful for your loved ones. If your healthcare agent is helping to make decisions and they have some sense of what's important to you, that can help guide them. I won't pretend that these conversations are easy. I will confess I have been meaning to have one with my father, and I haven't quite figured out how to do that. It's one thing to coach other people. It's another thing when it's the people that you love. So I feel that with you. But it does help us when we know a little bit about you and about these important questions. I'll close also by saying sometimes these conversations can feel a little doom and gloom, and it's all about the end. And I will say that I think the most important thing about having these conversations isn't being prepared for the what ifs. It's actually thinking through, and we can all do this, how do I want to live now? What's most important to me now? And what do I value? And maybe just having a little bit of time to reflect on that can change how you live. I will end with a quote from Viktor Frankl, because I get a lot of strength from him in these times. But he said, life is not primarily a quest for pleasure or a quest for power, but a quest for meaning. And the greatest task any person has is to find meaning in his or her life. And so I hope some of these conversations can help you with that task. Okay, I am going to introduce Dr. Helen Delacadios.
Thank you. Can everyone hear me? Can you hear me, Juliet?
Yeah.
Great. I'm Helen Delacadios. I'm one of the primary care doctors here at MGH Beacon Hill, and I'd just like to introduce my daughter, Nina. Some of my patients may have met her before, and she's going to be my culinary assistant, and we're going to take a short detour into healthy eating and healthy cooking, not only during a pandemic, but in general. However, during this pandemic, things are a little extra challenging, and in some ways, we spoke about this topic about 2 months ago. Things are changing a lot. Initially, we were all very confined to our homes. However, now the weather's a little nicer. We are starting to venture outside, and as you've heard from the previous speakers, how to do that in a healthy manner in terms of just in general, but also eating. And since we only have a few minutes, we're going to just share with you some few tips. And in the interest of time, do you want to re-microwave or it's good? We're going to demonstrate a recipe of chocolate-covered strawberries, which is not very, very difficult. However, it's something fun and something that you can do with your family or even alone. I think it's important during this pandemic that we not lose sight of our nutrition, because if anything, it's more important now than it has been in the past, because keeping our bodies healthy is important to stave off, to prevent getting infected, and also if we do get infected, to help with taking care of it promptly. Just some few anecdotes. I have heard many people cooking more at home, which is great because generally when we cook at home, we make healthier choices. I have also heard maladaptive responses where people are taking the liberty to eat more processed foods or frozen foods, and any change in circumstance can lead to changes in nutrition, which can therefore lead to changes in the medical conditions that people have. And what I'm going to talk to you today, since I don't have slides, I think it's easier to have little tips. This concept of culinary medicine, and that's a concept of using food and the art of cooking and food and how to treat how to treat diseases using food, because food is medicine. And the concept of this chocolate covered strawberry, we're going to talk about the dessert flip. So many times when we think of dessert, we think of either a big piece of cake or cheesecake or something very sweet, and maybe there is a strawberry or half a strawberry on the top. And what Nina's going to demonstrate for us here is how to use fruit and maybe some nuts as the centerpiece and using chocolate as a garnish. So we flip it around. So that's a good concept to think about, where you can still satiate your sweet tooth, but not with a lot of calories and sweetness. And then the other principle we're going to demonstrate very shortly is make it yourself. So maybe I'll transition to you and you can show them the basically 3 ingredients that we're going to use.
So today we're going to use dark chocolate. You can either use dark or milk, whatever your preference is, but like a brown chocolate. And then also some white chocolate for making designs and stuff. And I just measured it out here, just kind of like a small portion of chocolate chips, however many you want. And then I just put like maybe a teaspoon of coconut oil, and that just helps it become a little bit more liquidy when microwaving it. If you don't like coconut oil, you can't really taste it. If like you really just don't want to use it or you're allergic or something, it still will melt without it. It just makes it a little bit easier. So I already went ahead and microwaved it. So I have like my liquid white chocolate and dark chocolate. And I'm just gonna go ahead and do some of the strawberries. Do you wanna
Show you?
Yeah.
Which
Sorry, not stop video. Here. There we go.
Okay, so I'm going to focus on Nina's hands as she's basically preparing the chocolate covered strawberries.
So you're also gonna want to get some wax paper ready just to lay it down when you chill it.
And just so you know, we're not in our kitchen, which we've done this before. We're in my office, so it doesn't take a lot of equipment. You can do this anywhere, but your kitchen is fine. Yeah, go ahead.
So the chocolate one, I just kind of swooped it all the way around and nothing too crazy. And then you just gently lay it on here. That was kind of crazy. And then for our peak design of class, we're going to use white chocolate. So when you have a strawberry that kind of has like a face and a skinny side, you're going to want to take the face side and dip it in the white chocolate, just kind of the front part like that. And then you're going to put that there to chill. And I'll get back to that one in a moment.
These recipes will be forwarded to you, or maybe already have been forwarded to you if you're interested in trying. This used to be a big hurdle. I was like, oh, chocolate covered strawberries would be fun to make. I thought you needed a double boiler, but actually you can do it in the microwave. So it's very simple, as you'll see. And then you'll tell us what to do.
If you have like extra chocolate instead of just eating it, because that's a lot, you can just look in your pantry and see if you have any dried fruit or nuts. So today we're going to take some apricots, and you can just dip those and gently place them here, either in the white or dark. And then you can also take some nut cluster, some nuts, and just pour them in there, mix it around.
So we've got fruit, nuts, and dark chocolate, all makings of a both delicious, sweet, and on the healthier end in terms of desserts, as desserts go.
Yeah, so then, yeah, here, I'll put this and you can take that into the fridge. So then you're going to want to put that in the fridge for minimum like 10-15 minutes, but definitely better if longer. But if you only have 10 or 15 minutes, that's totally fine. If you want to speed it up, you can pop it in the freezer.
So here we go. Time lapse photography. 10 minutes go by and we've got our nicely covered, or let's do that again.
Strawberries.
Flip it again.
Okay, so now we're gonna flip it again and show
So
you some of
look,
the designs.
Aren't they beautiful? Now Nina will show us. Go ahead.
All right, so now for our peak design, we're gonna select one of the strawberries. These ones, I think I put a little too much coconut oil, so they're a little bit lighter on the white chocolate. Basically, you're gonna take one that has the white to side. Oh, I got a nut cluster. And then there you have a little thing, and you might be a little confused with what's going on. And then you take a chopstick or a toothpick or something, and you draw 3 little dots, and then a little bow tie.
So I have a small screen. Is that coming out okay on people's screens?
Yep, we can see it.
Okay.
Yeah, so then you have a little tuxedo, which is super cute and just a fun little design that you can do at home.
Oh, wait, flip it around.
Or you can just put it on the side.
Oh, this is the concept which we just did. Whether you're alone or with someone else, with kids, grown-ups, your partner, or just by yourself, have fun. And then
Yeah, and
why
then
don't you do your other design?
you can do some other things, like if you don't really like white chocolate, you can have dark chocolate as the base, and then take a little bit of white chocolate and just get it ready, and then start at the top. And then do a little drizzle like that. And then you can also do the opposite.
I asked my assistant to come do this because she does this very well.
You don't need to do anything crazy.
When I've practiced doing this, I just do the dark chocolate. And now we're gonna get to our final tip. This is the final tip. Savor. So Nina's gonna demonstrate because I'm gonna talk, but she's gonna take one of the chocolate covered strawberries and smell it. You guys can't smell it. When I do these food demos in person, you can actually smell it. Look at it, appreciate the colors and the designs, the beautiful designs. And then as you start putting it into your mouth, take a small bite. And they say that for dessert, it's really the first bite that really counts, because after that, people aren't thinking about food anymore. And then you can taste both the chocolate and the strawberry and also feel it on your tongue. And just reminder to enjoy while you're also eating healthy and nourishing your body. Any final thoughts or comments?
The nice thing about the chocolate covered strawberries and just like small recipes like this is it's difficult to overeat, because you can just treat yourself to 1 or 2 strawberries rather than a cake or something where you can cut yourself a really big slice and end up overeating. So you can make nice strawberries and then have like 1 or 2 after dinner rather than an entire cake.
And I like simplicity. All you really need is the chocolate, the strawberries, and just a little bit of shortening or coconut oil to make it smooth. So I'm gonna pause there, and I think we're gonna turn it back to Susan, who's gonna lead the Q&A.
Thank you so much. I wish there was a way we could get everyone participating today a chocolate covered strawberry. This always makes me so hungry. So thank you. That was wonderful. So we do have quite a few questions, and I am just gonna, one quick comment I'm gonna make is that we did get a few questions from people about who is Atul Gawande. And Atul Gawande is a surgeon who practices at the Brigham and Women's Hospital. He also is very involved in a coalition across the state of Massachusetts. He co-leads this to help us improve the care that we're providing to people with a serious illness. And he also is a writer for The New Yorker and has written several books. And the one that I would recommend, that I think is actually his most well-known book, is a book about his experiences with his father when his father had a serious illness, and it's called Being Mortal. So with that, I think one of our first questions came in, and there's sort of two, and this is for Dr. Rodriguez. There's a question about how reliable are the PCR tests, and another question, I'm 73 and I'm in good health. How do I get a test? So could you speak to both of those?
Definitely. Well, by the way, I'm just happy to work next doors to Dr. Delicatio's office. So, uh, of course, respecting social distancing and wearing mask. I hope there will be some leftovers. But go answering the question, how reliable is the PCR? As we mentioned, those tests are very time dependent. The PCR will have a higher probability of being more efficacious during the first 1 to 2 weeks. And it's not a perfect test. We know that about 1 in 5 patients may actually have a false negative result. What it means is that they may have the infection, but the test would still be negative. And as we mentioned, one of the uses of the serologic tests would be, an adjunct or a helper to the PCR test in some circumstances in which we know we have a patient that has a typical syndrome of COVID infection and has a negative PCR test. Regarding also the serologic test, how efficacious it could be, or it is, after 2 weeks, it has a sensitivity of over 90% and a specificity of over 99%. So it's pretty good test. How to get tested? I mean, my first question would be why? Right? So sometimes we want to get tested because we are curious about, do I have it? Was I ever exposed? And when we leave our safe haven, our safe place to be tested, we are always exposing ourselves to a possible infection. Right, so we have to be careful about that. So the first step to be tested would be talk to your primary care, okay, and discuss with him or her about being tested, and he or she will guide you about the next steps. In Mass General nowadays, we have several branches or testing stations where we can provide testing.
Thank you. Another question that I think is a really important question, and I'm going to give this one to Dr. Jacobson because you've had a lot of experience with people that have COVID that are in the inpatient setting. And the question is, controlling for pre-existing conditions, how much does mortality increase with age?
Here, Juliet, before you answer, Omar
Yeah.
would like to say a quick hello to all our patients.
Oh, good.
Good afternoon, all my patients. I don't think they're gonna know me when I'm wearing a mask. Maybe it will take for a few seconds because
Yeah, go ahead.
this is Omar from MGH Beacon Health. Wish you the best all. Hope you're having a safe and a good summer, all right?
Thanks,
Thank
Omar.
you.
Thank you. So back to Juliet, Dr.
So,
Jacobson.
we know that both age and comorbidities are a risk factor for mortality. And we see the increase at around age, 70, some increase, but really starting at age 80, where people are more likely to get sick. And what I always say to patients, the patients that I see in the emergency room is, most patients, for most people, this is a mild illness. Even for most 80-year-olds, this is a mild illness. There's a small, 15% of people who might need to be hospitalized. And then there's a very small number of people who may die from the illness. And of course, that's going to go up with age and with comorbidities. And I think we're all working so hard to figure out what other treatments can mitigate that and help people, knowing that this virus is worldwide, help people if they do get it to be able to get through this. So those are real risk factors, and the numbers do go up. But we are working to try and figure that out.
Thank you. Dr. Riley, we have a question about how much distance do we need from people to protect ourselves from the small molecule aerosolizing? And how do we deal when we're around people that are runners or on bikes and that sort of thing?
Yeah, it's very difficult. So we do know that this can be transmitted through aerosolized particles as well. And the masks will prevent aerosolized particles, many of the aerosolized particles, as well as the droplets. But 6 feet of distance is still very important, not only for aerosolized, but the droplets, and further away is important as well. So it's going to depend on ventilation. If you're inside in a poorly ventilated area, or an area where someone has been without a mask, maybe they've been coughing or sneezing, you should try to avoid spaces like that, which is why if you go into a store, everybody has to wear a mask. The ventilation may not be that good. They're trying to keep people distance, but it can be difficult at times. If you're outside, there's a breeze, there's space between people while they're exercising, then hopefully people around you are wearing masks when they're exercising. If they're not and you're outside, you should wear a mask. If you see other people around you or they're coming close to you, do all the things I'm sure you're doing. Change to the other side of the street. If you see someone coming, put your mask on. When you're 10, 15 feet away from them and we're away from you, their breeze is blowing, you could take your mask down again. I know it's becoming very difficult with the weather getting hotter. But if you're near a person and you're talking, or you're running with a friend, you're biking with a friend, at all times when possible, you should leave the mask on.
Okay, I have a related question for you, and that is, is a cloth mask sufficient if you are high risk and people are not wearing masks and coming closer than 6 feet? Would a surgical mask or an N95 be better? And are there alternatives if one is sensitive to Purell?
So in terms of masking, just to give you a sense, even what we wear in the hospital, we're all wearing surgical masks in the hospital, unless we're in the coronavirus units themselves, and then we have N95s. But if you are in a situation where someone is talking to you and they do not have a mask on and they're closer than 6 feet, a surgical mask would be better than cloth mask. A cloth mask is better than nothing. And when I say cloth mask, as you've noticed, there are a lot of different masks out there right now. They're made of different materials. Some of them have different numbers of layers. So it's a little hard to assess which cloth mask could be better than others. But we have a little bit more reliability on the surgical mask. So if you're high risk and you know that you might be exposed to someone within 6 feet, then surgical mask would be better. And Susan, what was the second question?
What do you do if you are allergic to Purell? What are the alternatives? If you're
Soap and
sensitive
water.
to it.
Soap and water, if you're able. So if you're able to get to soap and water is actually better than Purell. And I think we use Purell or Calstat or any of these other alcohol-based hand washes when we can't get to soap and water. If you're in a similar situation and you also can't get to soap and water, I've had some patients who have a baggie with a towel in it that has some soap in it that's wet, and another baggie with a very wet washcloth, and they kind of use one and then they can use the other. So not ideal. It's a little cumbersome, but you should try something like that to wash your hands.
Okay, thank you. I have a question for Dr. Calcorn, and that is, the question is, telemedicine offers an opportunity to more effectively promote self-care. And this is actually something that's near and dear to my heart. What is Mass General doing to capture this opportunity and to better support our patients to, get more involved in managing their conditions when they're at home?
That's a great question and great point. So Mass General's moved very quickly to kind of get our virtual visit platform established. And I think, part of it is having multiple different modalities available to people based on what patients have available to them. So it's making it possible for you to have a telephone, a dedicated time to talk to your doctor by phone where it's not interrupted by other things, or dedicated time to have a face-to-face visit with your physician. So those platforms are in place. The other thing that we've been doing is we've been reaching out to some of our patients that we haven't seen in quite some time and really making sure that we have some sort of interaction with them so that, in the age where people feel like maybe I can't access my doctor's office, we're letting them know that, you know, your doctor would like to see you, to have a virtual visit with you. So you may be getting a call from either our front desk staff or another member of our staff if you have certain medical conditions like diabetes or high blood pressure that just hasn't been checked on in a little while, or if it's just you haven't been seen in the office for 2 or 3 years. We are trying to kind of leverage our virtual tools to be able to reach you at this time, so we can make sure that you're staying healthy, even if you can't necessarily make it into the office.
And I think I would add a little bit more based on what we've learned from some of the other practices. I think one thing that's much easier to do with a virtual visit is to actually allows your doctor to see all your medications and make sure that you're not duplicating medications. Sometimes people get a generic prescription from a specialist and a brand name prescription from their PCP, and it's the same medicine, but they don't know that. And so I think it's really improving the way that we're supporting our patients to take their medications correctly and make sure that everything you're taking is appropriate. And I know that in some instances, we're also able to provide blood pressure cuffs and other things to people at home so that you can monitor your own vital signs more effectively. One quick comment I want to make is that we got a lot of messages to Omar. So I don't know if Omar can still hear us, but people were very happy to see him there. He is terrific, and bravo. What a wonderful, informative, and positive style. So just please make sure that Omar hears that from everyone. And then we have, I think, a question for those of us who like to eat. Helen, the question is, can you give us some guidance for family barbecues and other get-togethers with social distancing and food sharing where somebody may be handing you something on a roll, or how do you manage that?
Yeah, no, I was just talking to a patient this morning. We were talking about deck visits with people who are family who want to see each other, but you want to be cautious. I mean, I think the safest thing is to bring your own everything, bring your own drink, bring your own food, bring your own chair, bring your own utensils. However, you can be somewhat a little bit more liberal, and if you're serving hot food, potentially go straight from the grill to the plate. It's a matter of just how at risk somebody is and what safety precautions are in place. I don't know if any of the others want to pipe in with their thoughts on the matter as well, because it's beyond just food. It's food plus safety.
I think, no, you make good points. And I think when people are serving other people, just like you see some ads on TV about no touch service, you know, you can, as Helen was saying, you can serve something with a spoon or tongs to someone else's plate. You don't have to kind of hand them food, or maybe drinks can be within a big container that people take out themselves. And so I think reducing the amount of possible touches between hands, and then of course doing careful hand washing makes sense. And if at all possible, bringing the food that you're going to be eating is certainly the best.
Yeah, and my daughter adds no family style, which is so antithetical to everything that in our family that we do in terms of sharing food. And I've got all these great chocolate covered strawberries that I would love to give out, but unfortunately I can't. So that's unfortunately where we are at this point.
And I would ask if you have any recipes in your recipe box that are healthy food for picnics, or we're coming up on the 4th of July. If you want to share those, we can also share those with everybody.
Yep. I think you have my website, so there's some examples there. And yeah, the unfortunate thing is you can't really share many things because once you cook it and you handle it, you just want to be extra careful depending on who you're sharing it with, at what risk level they're at.
Yeah.
So one more thing I'd just like to mention is at those family barbecues, because I know they're going to be happening more and more. Again, if you're all together and you're masked, that's great. But when you eat, you have to be sure to be 6 feet away from the people around you. So all the people at the party sitting at common tables, you need to create some space or find another place to eat.
Thank you. We have another question that I'm going to ask Dr. Rodriguez to respond, or anyone else can jump in. But the question is, are you more susceptible to COVID if you have type A blood?
That's a great question. And not that you are more susceptible to acquire the infection. What the studies have been showing is that you are more successful to have a more severe infection. Patients with non-O blood, mainly A blood type, are more successful to have a more severe infection.
Okay, thank you. So we are almost at the end of our time. I just want to remind people that when we have the recording ready, we're going to be sending it out to everyone, along with several other resources that we think might be helpful, including delicious recipes. And so those will all be going out probably next week. And I'm now going to turn it over to Dr. Riley just to say goodbye to everyone.
So thank you again, and thanks to all the presenters. You just, I think for the patients, I hope it was somewhat comforting to see your doctor or see Omar, and we certainly wish that we could see all of you. It's been great having the ability to interact with all of you with virtual visits and telemedicine in the times when we weren't able to come into the office at all, and we're looking forward to seeing you again. And I hope this provided a little bit of information to kind of get you through what I hope is a safe and healthy summer. You know where to find us now, and there's to be no barriers to getting the care that you need. So please use all the numbers, as Dr. Kilcoran said, that you're used to using to access us for care. And at any time, if you need us, we are here. So I hope you have a good and safe.
Thank you. And I will just add, just as we're closing, that I actually had a conversation with my PCP about when it would be okay for me to come in and be seen. And she reassured me, and I really trust her, that probably one of the safest places to go right now is into the hospital or into a practice, giving all of the precautions that we're taking to make sure that everything is safe and will keep you healthy. So with that, I hope you have a wonderful rest of your afternoon, and thank you so much for joining us today. Take
Thank you,
care.
everyone.
Bye-bye.
Thank you.
Bye.